is Jim Finch. I'm a family physician by training, but I have practiced addiction medicine for many years, often with patients with a combination of substance use problems as well as chronic pain. With that background, in this video, I will be talking with you about discontinuing opioids, giving news patients don't want to hear. When choosing to use opioids in the management of chronic pain, the goal of risk assessment and careful treatment planning and monitoring is that these meds provide relief while being used safely. But even with the best of intentions, it will at times become apparent that it's no longer safe or appropriate to continue using these medications, and the clinician must then discuss these concerns with the patient. At a minimum, this encounter can feel awkward for the clinician and can be disappointing or even alarming for the patient. At the worst, it can be dangerous to the clinician and put the patient at risk of moving his or her dependents to the street. As described and discussed in another video, a number of factors go into deciding this clinical change and how it's implemented. These factors relate primarily to issues of safety and persistence of problematic behaviors, but also to issues of legality. Setting aside situations that relate primarily to an opioid's ineffectiveness in terms of pain management, other scenarios that often require discontinuing opioids relate to the patient's inability to use them as prescribed, such as patterns of overuse or other inappropriate use, or use that puts them or others at risk. This would also include concerns about diversion of the medication to others. How urgently the clinician responds to these scenarios generally depends on how much risk is perceived to be associated with continued prescribing. Misrepresenting and diverting meds to others comes in a variety of forms, but in the case of overt scamming and diversion of medication for profit, the clinician should immediately cease prescribing the medication and consider making a report to law enforcement. In the situation of illegal activities, there's no need or requirement to give a last prescription or to allow time to seek alternate care. However, if the individual is physically dependent, safe referral options for withdrawal management should be provided. So, how might this sound? Mr. Jones, since I last saw you, it's come to my attention you're diverting some or all of your prescription to others. This is not only a legal concern, but a safety concern as well, and as a result, I will no longer prescribe this medication for you. Mr. Jones might respond, "Who told you that? That's not true." Well, unless you have very concrete specifics, you do not have to justify your decision further. I'm not going to discuss the specifics, you might say. But it was enough to convince me that I can no longer prescribe for you. But I need these. If I don't have them, I'm going to go into withdrawal. That could be true, and that would be a tough situation for you. Here's the number for the local detox and the local methadone clinic. But again, I will not provide further medication. This is one of the situations where the clinician should stay alert to his or her own safety. Consideration should be given to not seeing the patient alone and being alert to the need and ability to exit the situation. Threats should be responded to calmly, explored, and taken seriously. Less dramatic but more common clinical situations include cases of medication misuse seen as relatively low to moderate risk. For example, isolated or infrequent occurrences such as occasional overuse in managing incident pain or an isolated positive drug screen. The clinician may not think it necessary to discontinue the opioid, but may reasonably respond by changing the dose of the medication or increasing monitoring or seeking consultation. All of these may seem reasonable to the clinician, but may be seen differently by the patient. So how might this sound? Ms. Thomas, this is the second time you've had to come in asking for an early refill on your medication. You explained that when your pain flares, you take more than intended, and you later run short. So we're going to reconsider some other ways to help you with your breakthrough pain, and for the time being, we'll shorten the time between your visits and your prescription refills, so you'll be maybe better able to keep track of what you're using. Though reasonable, Ms. Thomas may say, "I can't be bothered with that. I just need a bigger prescription to last longer." I don't think that would be the safest option. I believe it could lead to greater reliance on the opioids and increase the risk of overuse and accidents. Plus, it's important that you show that you can manage these medications so I can feel safe prescribing them. On the other hand, in situations with high relative risk, such as following a near overdose or a serious accident, or patients who have recurrently shown themselves unable to safely manage their medication, even after adapting the treatment plan, sometimes multiple times, the clinician may see the need to discontinue the opioid medication and will need to discuss this with the patient. In these situations, it's necessary for the clinician to be caring, but also firm. It's important to hear and understand the patient's concerns about pain, function, or possible withdrawal, but it is not necessary that the patient agree with the clinician's decision. For example, you might ask if the patient understands your concerns or reasons, but you don't need to ask, is that okay? The approach should be kept non-confrontive and avoid accusing or labeling, and the emphasis is best kept on issues related to safety. Whenever possible, be clear about specific unsafe situations that have been documented. Finally, it is important to be clear that you are not abandoning the patient. You can make it clear that you will continue to help manage his or her pain, but without continuing to prescribe opioids. So what might this sound like? Over the past month, it's become increasingly clear that you cannot safely manage your opioid prescriptions, and I would be putting you and others at risk if I continue to prescribe them for you. So I am no longer going to do so. The patient might say, you don't think I have pain, you just think I'm an addict, that I'm making it up to get pills. I'm not denying that you have pain and that you will continue to need treatment for that pain. What I'm saying is that you also have a serious problem with your dependence on opioids that has taken on a life of its own, and it needs treatment too. And here are the treatment options I would recommend for you. I'll be happy to continue to work with you on your pain management and other medical needs, but as I said, I will no longer prescribe opioid pain meds. So we need to talk about options to get you off. Obviously, an important aspect of this encounter is to have thought through the treatment alternatives that would be appropriate for this particular patient. Traditionally, alternatives have included tapering, referring to medically managed withdrawal, or referral to a licensed methadone provider. Another effective alternative now available is substituting the partial agonist opioid, buprenorphine, for the full agonist opioid the patient's been misusing. Buprenorphine is a good analgesic, but its characteristics make it much less rewarding and less likely to be abused. Substituting this medication is most easily accomplished if you or another clinician in your office are DEA waivered to prescribe buprenorphine. However, the DEA waiver is not required for prescribing for pain rather than addiction. In my experience, this message becomes much less distressing. Rather than, I will no longer be able to prescribe opioids for you, it becomes, I will no longer prescribe the oxycodone, morphine, whatever, that you've been on. The only opioid I can safely prescribe for you now is buprenorphine, which you may have already heard of. It's still a very good opioid analgesic, but it will be easier and safer for you to manage, and I can then continue to work with you in other ways to manage your pain. If the patient does not want any of these options, it is then necessary to assess and educate him or her regarding the symptoms and risks of withdrawal, including the risk of overdose. The patient can be given contact information for the local community detox center and opioid treatment programs. And if it has not been done already, it would be judicious to offer the patient and/or family members a naloxone prescription with instructions on when and how to use it. Finally, I should mention one other option sometimes used by prescribers. Often out of frustration, treatment is terminated, but they provide one last 30-day prescription to taper off or to find another provider. This seldom makes clinical sense. First, if the patient has been unable to manage his or her prescription in the past, it's unlikely that they will be able to safely manage this last prescription. As importantly, it does not make use of this crisis as an opportunity to acknowledge the substance use problem and seek appropriate help. In conclusion, saying no to a patient who is set on a particular treatment is often not easy. This can be particularly true when physical dependence, perceived need for pain, as well as other emotional dynamics complicate the situation. But safety for the patient and others has to be paramount, and at times it is necessary to be firm in changing the treatment plan. Thoughtful preparation and a caring approach can help make this at times difficult encounter more tolerable and effective for both patient and clinician. Thank you.